Hi everyone, I am Francesca Cerutti, Diamond member of Style Italiano Endodontics. Today I would like to talk to you about clinical precision simplified with the R1 mini kit. So let's start with the fact that our everyday reality in endodontics used to be many files, long sequences, maybe difficult protocols, different settings between the files, etc. And so there was the need and the request to make these sequences smaller, easier to understand, easier to apply, and also to make files less aggressive, because when we used single seal files, we faced a lot of problems linked to the creation of ledges, blocks, wrong paths, maybe file breakage. And so companies listened to the requests of the users, of the dentists, and started developing different files. Engine-driven files with different design, different tips, different alloys, in order to make our job easier and more predictable. And so what was one significant change into the movement of the files into the root canal system? Reciprocation. Reciprocation is a movement in which the file moves back and forth. What does that mean? That the file engages the dentine in one direction, in which it proceeds into the root canal because it's cutting, and then it doesn't do one complete turn. It stops at a certain point and then makes a smaller movement in the opposite direction. This is meant to disengage the spires of the files from the dentine, and so making the movement safer, because in this way the torsional stress accumulating on the file is reduced, and so is the cyclic fatigue. And so this was meant to make almost everyone capable of doing a root canal treatment, because with the reciprocation movement they said it was easier and safer to do a root canal treatment, which was, from my point of view, the biggest problem of files sold to be used with the reciprocation motion. The fact that they were sold as single files. So we had the myth that we would have been able to shape every kind of anatomy with a single file, which could be applicable in an easy anatomy, because sometimes we do use only one file to shape completely the canal. Okay, I'm not against this, but it's not for every tooth, not for every anatomy, and above all, not for every practitioner. Because if they give an experienced operator a reciprocation file and they tell him, okay, do the root canal treatment, even in a very curved case or calcified tooth, etc., maybe that experienced operator, even if facing some difficulty, will be able to complete the treatment. But if you give the same instrument and the same case to treat to an operator which is not experienced, maybe a student or a freshly graduated doctor, then we might have a problem. Because even if the reciprocation motion is safer, because the file accumulates less torsional stress and less cyclic fatigue, still, if they are not used correctly, the shaping movement of this file is more likely to accumulate debris inside of the root canal system. So an unexperienced operator could create blocks inside of the canal, and then continuously packing this debris inside and not being able to finish correctly the root canal treatment anymore. And so we have to be careful. We have to take the reciprocation motion, which is okay, which is good for many cases, and try to consider that we cannot do everything with a single file. Some cases can be done, some cases cannot. And so, starting from the fact that it's impossible to do everything with just a single instrument, let's see if with a short, small sequence, we can do almost everything. And this is what the 𝗍𝗶𝗰𝗶𝗀 is trying to do. So, with only 3 files, which is 1 early coronal flarer and 2 files that are meant to shape the canal, they tell you, okay, with this, you can complete the vast majority of cases. Why? Because with the first file, you remove coronal interferences. The second file will act as a glider, so you will achieve and you will complete your glide path with this file. And then with a slightly bigger file, you will be able to shape the canal. So this is the philosophy that is lying behind the idea of the 𝗍𝗶𝗰𝗶𝗀. But let's go more into detail into this kit. So the early coronal flarer, which is the first file that you see in the kit, is 19 in tip and 5 in taper. And the maximum file diameter is 1.1. So still it's a conservative file, okay? The working part is 13 millimeters long. Why? Because this file is meant to be used only in the coronal part of the canal. So there is no need to have a longer working part because you don't need it. And the pitch is short in order for you to be able to control more easily this file. The cross section is double S section. And this file can be used also in continuous rotation. The people who invented it suggest you to use this file in continuous rotation. Slow speed, 250 rotation per minute, and then you just remove the coronal interferences. Once you're done with this file, which takes few seconds, you can use the 1704. So the 1704 is the file that you are bringing to the working length for the first time. This is smaller. The maximum file diameter here is 0.8, and the taper is regressive. The alloy is an AFL wire. What does this mean? It's a heat-treated alloy which is flexible but has a very nice cutting efficiency. And how you set this file? You set it in reciprocation motion. So it works in a counterclockwise motion when it cuts. So 150 degrees counterclockwise, 30 degrees clockwise. 150, 30. This is how the file works. So it engages the dentine, it cuts, then it disengages. After 3 or 4 strokes, you remove the file, you rinse, and then you put it in again until you reach the working length. And then you have the shaper. The shaper is a classical 2506 file in AFR wire, which is extremely flexible but still has a good cutting efficiency. A little bit less cutting than the AFL wire, a little bit more flexible, because the first file, the 1704, has already traced a path for you. And so this file, the 2506, only has to follow the path that has been traced from the previous one. So you don't need it to be super cutting, you need it to be pretty flexible. But still remember that the double S cross section is cutting in nature, okay? So these are excellent files if you want some cutting efficiency. Even in this case, the file works in reciprocation motion, so 150 degrees counterclockwise, 30 degrees clockwise, and you're going to finish your treatment. And then then you do the visual gauging. If you have shaped the foramen correctly, then you can stop. If your foramen is larger, then you can take another file and enlarge it a bit more. But some cases can be finished only with this 2+1 file. So the philosophy of this sequence is to use less files, but in a better way, in a smarter way, okay? So every file has a clearly defined role. As I was saying before, the first file only in the coronal third, so you use it to remove coronal interferences. The second file, the 1704, has to be driven to the working length, and it can be followed by the 2506. And this works in moderate canals, straight canals, no particularly difficult curvatures, etc. You can use this sequence. If the case is complex and you feel like you're struggling a bit to reach the working length immediately, well, this is what you can do. You use the 1704 until the middle third of the root canal. Then you use the 2506 until the middle third. So you remove some more coronal interferences. And then 1704 again to the working length, 2506 again to the working length. So by adding this intermediate step, you can solve more complex anatomies, more complex cases, without increasing the number of files that you are using, just playing smart with the ones that you have. We already mentioned the difference between the alloys, so the AFL wire is slightly martensitic. The 1704 is a small file, so regardless of the alloy, it's going to be quite flexible. Of course, if we add the fact that there is a thermal treatment, the alloy becomes slightly martensitic, so it gains something in flexibility. But still, it's a very nice cutting efficiency. The 2506 is AFR, so a little less cutting, a little more flexible. And we have explained before the reason behind this choice. So the first file that I drive to the working length has to be a little stiffer and a little more cutting. The other files can be softer, so more flexible and a little less cutting. And what about the geometry of the file? Why this cross-section is helpful above all if we are using a reciprocation motion? Because by having two cutting blades, the instrument works centered into the root canal and there is a lot of room for debris. I said before that the biggest problem with reciprocation motion is the fact that debris tend to accumulate inside of the canal and to be packed inside the canal to form blocks. So if we have a lot of room for debris, we have a lot of room for the debris to come out from the canal, and we don't risk that our instrument will get stuck inside, okay? So also remember that we combine 3 to 4 strokes of the file with some irrigation in order to make sure that we remove all the debris from the canal before working for too long inside of it. Another point to be clarified about the SS cross-section is the fact that by nature the files with this cross-section can be more resistant to cyclic fatigue than files that have a different cross-section, maybe a triangular or rectangular cross-section. And so if you combine this particular cross-section with the reciprocation motion with thermal treatment, you have a file that is meant to last long and not to suffer too much from the stresses that the file usually accumulate during root canal treatments. So let's see some clinical case. This is a simple case. The difficulty here was to do the correct diagnosis, because this patient was sent to me from a colleague because they could not understand which the problem was, but the patient was extremely in pain. A simple observation under magnification of the tooth led me to the correct diagnosis. There was a crack. And so the patient has an irreversible pulpitis due to the fact that every time she chews, this crack is opening, and so saliva is going in, bacteria are leaking. And so what do? Isolation. I start lowering the cusps because it's an upper premolar in a patient with temporomandibular disorders, and so I don't want the tooth to split in two between one appointment and the other. And so this is what I do. I follow the crack. I see where it arrives. Okay, it doesn't arrive inside of the canal, so I think I can do the root canal treatment. I shape the tooth. I do my confit. You see the two openings of the canals are confluent at a certain point, so I double check it with a 𝗍𝗶𝗀𝗶𝗀𝗋 point and a file. And then what I do the obturation, and then I immediately seal and do a build-up, okay, in order to first prevent bacteria from leaking inside my root canal treatment because I put maybe a provisional material, and second, to ensure resistance to this tooth. Another problem, the biggest nightmare of people doing endodontics, is file breakage, file separation inside of the root canal system. We have seen that the fact that we reduce the fatigue and the stresses accumulating on the file decreases the risk of separating the file inside of the tooth. And so the fact that we combine reciprocation with heat treatment gives us a robust margin of safety while using this file. And you can see also from these papers that reciprocation motion has been studied extensively. So there is nothing left to imagination when we analyze the files that are working in this way. We know exactly their pros and their limits. So let's see how we can apply this concept to a real case. So irreversible pulpitis in a defective restoration. First thing first, we remove completely the existing restoration and the decayed tissue, because there are several reasons why we have to do it. First of all, we don't want to do a root canal treatment in the middle of bacteria. Second, we see better what we are doing. Third, we can evaluate the restorability of the tooth. And if the tooth is not restorable, we don't do the treatment. If the tooth is restorable, we have to decide which kind of restoration. So you see now I am removing the pulp stone and I am refining the access cavity with an ultrasonic cell. And then I start with the first file of my sequence, so the 1905. I use it only in the coronal third of the root canals. Here I have 4 root canal openings, and so I will use the file in the 4 openings. The important thing to notice here is that I'm not trying to push the file into the canal. I'm just letting the file work, removing some debris, removing some dentine, removing some coronal interference. No more than that. It doesn't have to do more than that. Okay, this is just to flare the initial part of the root canal. So once I have done this, I can irrigate and I can switch to the 1704. You see the file moves slowly, I irrigate. And you see here, I felt like I hadn't removed enough coronal interferences, so I slightly modified my excess cavity. The excess cavity is always dynamically modifiable. You have to modify it according to what you need. And so regardless of the phase of the root canal treatment in which you are, you can always modify the access to have a better entrance for your files, to have a better cleaning, to have a better vision, to have a better feeling. You can modify it. Now I'm using the 1704 reciprocation motion 150-30. Okay, even in this case I'm not pushing, I just letting the file work. Okay, and then I irrigate. I'm not trying to rush to the foramen. Here I'm checking the working length. I had 4 root canals, so I'm checking it in the 4 root canals. I'm writing the length of each canal, okay? And then what do I do here? I put some irrigant, because it's better not to work in dry canals. And what do I do now? I take my 1704 and I see if I can reach the working length in all the canals without pushing. If I can, good. If I cannot, I take the 2506, I remove some coronal interferences, and then I go in again with the 1704. Once I reach the working length in all the canals, I can change to the other file, 2506. And then I can check that I reached the correct working length. I don't like rubber stops, I prefer to watch the notches on the surface of the file. Then I can do my cone fit and my obturation. And then, since I did not do the restoration in this case, I just temporize, and then I can send the patient to the dentist who is going to do the restoration. So I finish filling, I do my postoperative, and then the other dentist does the restoration, the build-up, etc. And he sends me this post-operative with the restoration in place. Another case. Lateral incisor. You see there is a large decay. In this case I did a multiple isolation because I prefer to do so in front teeth. Also because if I can, I also do the post-endodontic restoration in this case. So you see I've removed all the decay. Now I am just refining the access cavity. And then I start with the R1 Mini 1905 only in the coronal third. And then 1704. Few strokes. I check the working length. You see 2506. I'm not spending a lot of time inside of the canal. You see the final diameter of my foramen was 50, so of course I have to work a little bit with other files in order to shape the foramen, and then I do my cone fit, final irrigation, dry, and then fill. Then with the e-heater I cut the 𝗍𝗶𝗀𝗃 point and I pack. I'm doing here a modified warm vertical condensation. And then with the e-filler I go and backfill the rest of the root canal. Once I've done this, I just wash away the excess of sealer and I proceed with the post-endodontic restoration, so it's a normal direct restoration. And you see the outcome. Another case, you see, root treatment. Because reciprocation motion was probably born to remove the 𝗍𝗶𝗃𝗃 from inside the root canal system. So this is the preoperative. I do a multiple isolation, even in this case. I remove everything, I do the 𝗠𝗶𝗃𝗃, and you see tooth and the post-endodontic restoration. This is how the file works. So remember, counterclockwise, clockwise. This kind of motion relieves many of the stresses that accumulate on the file. Here is another case, upper molar. You see I refine the access cavity with ultrasonic tips. 𝗬𝗋𝗋𝗋. Even in complex anatomies, you can use with no problem this sequence of kit. You see MB2. I go directly with the 𝗬𝗋𝗋𝗋 because I see it. And then 1704. MB1, DB1, DB2, palatal, and then 2506. In all the file canals, with no problem. With the reciprocation motion, you have a nice control of what your file is doing. And so even if there is a curvature, you don't risk to go straight. It's pretty safe as a way of shaping. You see with the irrigant now I'm checking the confluence between the canals, so the two mesial canals are confluent. So what does that mean? That I have to shape up to the working length only the MB1, and then I shape the MB2 only up to the confluence. And the same can be said for the distal. So I shape the DB1 up to the working length, the DB2 only up to the confluence. I do the 𝗠𝗶𝗃𝗃. You see that I preserved the original anatomy of the canal. I didn't alter it particularly, also because the file is pretty conservative in taper, in size. And this is the root canal filling. I fill the palatal, now I fill the two mesials. And now the two distals. And you see the confluence. I put the sealer in one canal and it comes out from the other. I pack a little bit. Here is single cone and hydraulic sealer technique. See the cavity, and then I immediately do build up in order to be able to lute an indirect restoration in a second appointment. Can I use it in continuous rotation also? Yes, I told you before. Here is an example. Lateral incisor, you see, I start doing the excess cavity. I try to make it as conservative as I can. And then you see 1905, 1704, working length. I take the 1704 to the working length, 2506 to the working length. I check where it worked, and then I do my 𝗍𝗶𝗃 point fit. Irrigation, ultrasonic activation of the irrigant, drying, and filling. And then e-heater, I cut the 𝗍𝗶𝗃 point. In this case, warm vertical compaction. A little bit of packing. Post-end restoration immediately. And this is the postoperative. And if you doubt about the capacity of these files to remove the 𝗍𝗶𝗃, you can easily see this video. Even in an upper incisor, so there is a large amount of 𝗍𝗶𝗃 inside, you see that the reciprocation motion can quite easily penetrate into the 𝗍𝗶𝗃 and then take it out from the canal. It can work also in teeth filled with carrier-based techniques. Okay, sometimes it just separates the carrier from the 𝗍𝗶𝗃 and it takes it out, or sometimes it eats the carrier directly. So they're pretty effective to retreat. You see here, typical carrier based. So I have removed the 𝗍𝗶𝗃. And then in this case I am using a braided technique with Hedson manual files in order to engage the carrier because it's highly engaged in the foramen. And then when I have secured the carrier, I just take it out. And I go on with my root canal treatment, okay? But you see that in a few minutes I was able to remove all the existing filling of the tooth. Here is another case of a retreatment. So you see the post has been removed, the 𝗍𝗶𝗃 has been removed. Then the difficult thing here was to find the patency of the canal, but once it was found, with the 𝗍𝗃 kit I easily shaped the tooth and was able to complete the treatment. So the important concept that we are stressing nowadays in endodontics is the fact that we want to respect the anatomy as much as possible. We want to preserve the pericervical dentine, we want to go minimally invasive. We try to reduce the diameter of the nickel titanium wire out of which the files are manufactured. We try to use small taper files. And so, of course, we want to be as adherent as possible to the initial anatomy of the tooth. In this case, using small and flexible file helps us, above all in the presence of curvatures, to maintain the original anatomy of the tooth. And also, we have a minimal risk of transportation or ledges if we use the reciprocation motion. And so, we just fit well into the description of minimally invasive endodontics with this kind of files. And this is an example. You see here is a canine, so it's not a difficult tooth, okay? I just do my access cavity, I do the shaping, and you see filling, post-endo restoration. But if you see pre and post-operative and you draw the shape of the canal, you see that it was not particularly changed by my shaping. So with the 𝗍𝗏𝗰𝗹 I was able to follow the path of the canal and to maintain the path of the canal, which is extremely important. And nowadays also we have to consider the economical part of our treatment, because we somehow have to justify why we charge that amount of money to the patient. And so if we have some files that work very well and we can use with confidence, well, that might be convenient for us. And if we have few files that we use per case, of course, we reduce the inventory and the price that we have to pay per each case. And also the fact that there is a very short learning curve with using these files, and this is in general valid for reciprocation files. They have a shorter learning curve than rotary files. And this means that if we want to teach someone else in our practice or in our staff to do a root canal with these files, their learning curve will be short, and so they will start early being productive and being efficient with this particular kit. And also, since it's easier to use these files and they can be used in most of the cases with success, well, the number of redos or failures that we have will probably be smaller. And so this is going to be good for the practice, of course. And so this is an example of the fact that the learning curve is short. This is one of the first cases that I did with the 𝗍𝗏𝗰𝗹. So what do we have to do here? We just have to avoid pushing, because the problem here is that there is a small curvature apically. Okay, and so if we engage the tip of the file in that small curvature and we push, then the tip of the file is gone. Reciprocation motion in this case helps us, because in general it's less risky to break a reciprocation motion file in that point with respect to a file used in continuous rotation. But you can see that I was pretty conservative, I respected the curvature, and I was able to deliver in a very short time a good root canal treatment. So, which is the roadmap that we have to follow if we want to implement our workflow? If we want to learn how to use one system, don't start with challenging cases. Start with the easy ones, then move to the moderate, and then when you have learned how to manage the first two, you can switch to the difficult. And then try to standardize your protocol. You know that for that file I have those settings, there is that sequence, I have all my irrigation steps ready, so you have a better workflow. And then try to document your first cases and say, okay, it took me this amount of time. my difficulty was this, was that, the outcome was this, how can I improve? And then case by case you see that maybe it will take you a shorter time to do them, or you will do them in the same time but with a better outcome. And so you will be able to see your progress and to see how your learning curve is going, how fast you're learning, how fast you're improving. And then when you know how to manage the easy one, then you can expand indications. You started with initial treatment, okay, I can use them in other treatments too. Or I can use them in continuous rotation in this particular case. But start with specific and few indications. And then you can move forward. So, putting it all together, R1 Mini is a compact kit used in reciprocation motion. The workflow is meant to respect the anatomy of the tooth due to the cross-section, the alloy and the taper of the file, and the time, because it takes few minutes to complete one shaping correctly. And then be relaxed when you use them, because they are extremely user-friendly. They will allow you to deliver precise and very nice treatment without the stress or the fear of breaking the file or doing a wrong path, etc., because they are extremely easy to use. So I hope that this was useful for you. Let me know if you tried the R1 Mini Kit and what are your feedbacks. Thank you, bye bye.